tell me I messed up and I need to do something different. It will not offend me along the way. So, all right, let's go ahead and get started. Call the meeting to order. So next will be discussion and approval of any adjustments to the agenda. All right, hearing no adjustments. Rosalind, do we have to vote on that one, or since there's no adjustments,
Yes.
or can we just move on?
Just say that someone needs to make a motion to accept the agenda.
Motion to
All right,
accept the agenda.
Second.
I hear a motion. There's a second. All right, we're good to go.
All right, we need to do the roll call. Dr. Ray,
Yes.
Commissioner Alon,
Yes.
Dr. Jackson,
Yes.
Dr. Braithwaite,
Yes.
Dr. Miller, Dr. Orto,
Yes.
Mr. Gregorio,
Yes.
and Dr. Glover. Thank you.
All right, wonderful. Thank you, everyone. Next on the agenda is review of the minutes from the prior meeting. Has anyone, number one, does anyone have any adjustments to the minutes or any concerns about them? I reviewed and everything looked in order. All right, if not, can we have a motion to accept the minutes as they are?
So moved.
So moved. Second.
All right, moved and seconded. Let's go ahead with the roll call vote.
Dr. Ray,
Yes.
Commissioner Alon,
Yes.
Dr. Jackson,
Yes.
Dr. Braithwaite,
Yes.
Dr. Miller, Dr. Orto,
Yes.
Mr. Gregorio,
Yes.
and Dr. Glover. Thank you.
All right, wonderful. Thank you, everyone. Rosalind, do we have any public comments?
No, sir.
All right, great. All right, next on the agenda is staff and program recognition. Director Jenkins, who would you like to recognize?
Thank you so much, and good evening to this illustrious board. While it's always tough, and I try my best not to show any favoritism, I definitely want this board to really recognize and acknowledge the efforts of our health education and community transformation team. As of lately, they have been very busy with a number of community outreach events, to include a prescription drug take back about a week ago at Peace Memorial Baptist Church, to also include trauma, the first ever trauma-informed care symposium that was spearheaded by Jess Pasquette, and also presentations at various conferences, but most importantly, COVID and flu vaccine outreach sponsored by our Bull City Strong team. I've just been personally amazed by all the work that has gone on within the last month. But more importantly, I've been really pleased with the collaboration and the teamwork within the team, really seeing each other just really help pitch in, whether it's carrying totes or whether it's just actually being there. So definitely want to lift up this wonderful team and just really thank them for the great work that they've been doing in the community. That is all I have, sir.
All right, wonderful. Congratulations to the team. Awesome work. I will say I was pleasantly surprised to see Deputy Director Stevens at the Duke football game on the field a couple weeks ago. Gained recognition there, so that was great to see. All right, so moving on, we've got a couple really good administrative reports and presentations. So the first one on the agenda is the State of the County Health Report, which I believe Bria Miller is going to present to us. Bria, if you're ready, go ahead and take it away.
Good evening. Give me 1 second. Make sure I have everything up. Okay, are you all able to see my slides?
Yes.
Sure are.
Excellent. Good evening, everyone. My name is Bria Miller, and I'm the Partnership for Healthy Durham Coordinator, part of the Population Health Team led by Marissa Mortaboy. And it is a pleasure to be before you again. This evening, I'm going to give a brief overview of some things that were included in our 2022 Durham County State of the County Health Report. So first, a little bit about the purpose of the State of the County Health Report. The SOCH report is submitted every year that we do not submit a community health assessment. It provides updated data from the most recent community health assessment, and in this case, that would have been from 2020, on the top 5 health priorities, which are affordable housing, access to healthcare and health insurance, poverty, mental health, and obesity, diabetes, and food access. In addition, it covers current information on our demographics, leading causes of death, emerging issues, and more. Similar to the community health assessment, this is a resource for residents in Durham that could be used for educational purposes, for grant writing, also to inform policies, budgets, and programs. The SOCH report is in alignment with the Durham County Government Strategic Goal number 2, which is to improve the health and well-being for all. We seek to improve the length and quality of the lives of people in Durham and to support the development excuse me, across the lifespan. So now looking at demographics. Durham County's population grew from 317,665 between the years of 2016 and 2021, and I'm sorry, and 2020, to 321,488 between the years of 2019 and 2021. While the proportions of most racial categories stayed about the same, the Asian population and Native Hawaiian and other Pacific Islander population grew by about 16% between 2019 and 2021. The proportion of males and females remained consistent, and the median age increased from 35.5 in 2020 to 36.3 in 2021. So now looking at infant mortality. So infant mortality is the death of a baby before they reach the one year of life. Please do see the reasons for health inequities here on the slide. The infant mortality rate is calculated by the number of infants who die in the first year of life in comparison to every 1,000 total births. And so the chart shows differences in infant mortality between races and ethnicities in Durham. Total infant deaths decreased from 147 in years 2010 to 2014 to 124 in years 2017 to 2021. There were a total of 25 infant deaths in 2020 alone. Infant mortality rates are more than 3 times higher for Black or African American babies than white babies in both spans of time. This is an increased gap compared to 2015 through 2019. So now looking at leading causes of death. Cancer remains the leading cause of death among Durham residents. Following cancer is diseases of the heart, cerebrovascular diseases, chronic lower respiratory diseases, and Alzheimer's disease. When looking specifically at year 2019, we see Alzheimer's disease in the top 5 causes of death, unlike the span of years between 2015 to 2019 collectively. Now looking at life expectancy in Durham County. So life expectancy is similar to previous years. We're still showing lower life expectancy for Black residents than white residents. The average life expectancy overall is 80 years old for 2018 through 2020. So now looking at changes in data at the top 5 health issues in Durham. First is affordable housing. In 2021, 48.6% of renters were considered cost burden in Durham, with the vast majority of those being burdened more than 35%. While this is still high, it is actually a decrease from what we saw in 2019, where there were 51% of renters considered cost burden. Next, looking at access to healthcare and health insurance. About 38% of Hispanic or Latino or Latinx population is considered uninsured, while only 5% of the white population is considered uninsured. Over the past decade, Durham consistently has a better ratio of healthcare providers per citizen compared to North Carolina and national averages. While Medicaid expansion will improve access to health insurance for the population overall, it is projected that Durham County and Chapel Hill, these two were lumped together, areas will see the second least impact in North Carolina. Now looking at poverty. The percentage of the population below 200% of the poverty level in Durham decreased from 14.1% in 2019 to 13.3% in 2021. While poverty levels decreasing is a positive indicator, higher salaries of those moving into Durham compared to those already living in Durham must be considered in this analysis. There are still significant racial disparities. The gaps between poverty levels and Black residents and white residents has increased from an 8% gap in 2019 to a 13% gap in 2021. Now looking at mental health. Severe depression and post-traumatic stress disorder, PTSD, rates have increased in Durham County and statewide from 2020 to 2022. About 24 per 100,000 screened for having severe depression in 2020 compared to 37 per 100,000 in 2022. For obesity, diabetes, and food access, type 2 diabetes rates have stayed about the same in Durham at 12.9% in the adult population. There's a slight increase of 0.3% in diabetes rates in the Asian population between 2017 and 2019. 87% of Durham County residents have access to exercise opportunities, which is higher than the state average. So now looking at some emerging issues. Durham County has one of the highest COVID-19 vaccination rates in North Carolina, which I'm sure you all are aware of. In February of 2023, we had administered 648,775 doses of COVID-19 vaccine. According to the CDC, approximately 95% of the population ages 5 and older were partially vaccinated, and 85.4% of the population is fully vaccinated. Also, in 2022, Durham County confirmed its first Mpox, formerly known as monkeypox case. Cases rose exponentially by the first week of August and then doubled each week. Case numbers began to flatten in mid-September of 22, corresponding to the administration of the Mpox vaccine. Then looking at gun violence, which we know is still an issue, but it is decreasing in Durham. Durham had 770 shootings from January 1st, 2020 through December 31st, 2022 through December 31st, 2022, which is a decrease from 971 shootings from 2020 and 793 in 2021. 247 people were shot in 2022, which is a decrease from 318 in 2020. Now looking at some goals and successes. Durham County government is ranked 62 of the top 100 healthiest employers in the nation and 4th in the triangle for healthiest employer. These awards were given to organizations that prioritize the well-being of their employees by their commitment to workplace wellness and exceptional health and benefits packages. Then looking at progress with the City of Durham's housing bond, there have been several projects that have been started. A couple to note is the renovations at J.J. Henderson Tower, as well as construction of the Elizabeth Street apartments. As you heard, I believe last month, Durham is ranked 7th amongst all counties in North Carolina for overall health outcomes. Now looking at the 2023 Community Health Assessment, we have completed our countywide and Comunidad Latina survey samples, and now we are in the writing process of the Community Health Assessment. In addition, we are also in the process of setting our top priorities in health issues. We're going through a bit of a different process this time that includes more data. So we are looking at data from our community health assessment samples, county health rankings, and we're hosting community dialogue sessions. And the 2023 Community Health Assessment will be released in the spring of 2020. Do you all have any questions? This report is available at healthydurham.org in English and in Spanish.
Yeah. Hey, Bria, this is Dr. Jackson. I have one quick question. I think I've asked this question before.
Okay.
So if we're the 7th healthiest county, who are the other 6? Wake
Is number 1, Orange, Union,
and some folk out west, right?
Union, Dare, Camden, Mecklenburg, Watauga, and Currituck.
Okay, that's east. Okay. All right, thanks.
Welcome. There any
Thank
other
you very
questions?
much, Bria, for the presentation. Really, really good. One quick question, and you might not know the answer to this yet. It's great news that the gun violence numbers are decreasing, say from 21 to 22. In your preliminary data that you looked at from 23, does it look like that trend is continuing or maybe going in a different direction?
I do not yet have the data for 2023, so I am unsure. I'll see if we can gather anything and report it back to you.
Dr. Ray, I'll just quip that there has been an enormous amount of support and awareness efforts around firearms prevention, as evidenced by the North Carolina Public Health Association really partnering with the state's Injury Violence and Prevention branch. We had a very dynamic pre-conference for firearms prevention, and that work continues now in the form of lunch and learns and a lot of different smaller symposiums on the campus of University of North Carolina, Chapel Hill, particularly the Gilling School of Public Health. So we are not letting our foot off the pedal, so to speak. We're going to continue to try our best to do our part, but that was certainly one of our main thrusts for last year during my presidency of NCPHA, and we're hoping to continue that, sir.
Wonderful. Thank you very much for those efforts. All right, if there are no other questions, Bria, I'm sorry. Thank you very much. Really appreciate it. Next on the agenda is the communicable disease report from Dr. Jenks. Dr. Jenks, go ahead and take it away if you're ready.
Great, thank you so much. Can everyone hear me?
We sure can.
Okay. And can you see my presentation?
Yes.
Okay, great. Technology is working. So pleasure to be here. And I know I'm one of 2 people now standing in the way of a long weekend. So I'll try to be as abbreviated as possible, but we do have some important things to go through here. So what I want to review today are kind of where we're at as far as sexually transmitted infection rates, bloodborne pathogen rates, foodborne pathogen rates, our TB cases, both active and latent, that we've seen over the past year. Briefly touch on some vaccine preventable diseases, and then touch on invasive group A strep. So a lot to cover, but we'll move through here quickly, I think. So just to kind of preface this presentation, the data in this presentation was polled October 16th. So there's still 2.5 months of data to accrue left in 2023. So when possible, we tried to predict, what the final numbers will be approximately at the end of 2023. Some of this data you'll see, it may differ from the data on the state website. That has to do with, again, kind of time when the data was pulled, as well as some data cleaning, differences in data cleaning. But generally, the data is going to be pretty similar. As with, kind of every year, all the data I'm going to present today is on, communicable diseases that are mandatory to report to the state. Now, that being said, not every time one of these diseases pops up is it reported to the state. So basically, the data I'm presenting is, limited based on, how often it's actually being reported. And then this didn't happen a lot, but, where there's really low cases, we suppress the data. And I'll talk about that when that comes. So I've mentioned this the past 2 times I've given this presentation, and I wanted to kind of, pull this out at the outset and just really kind of preface this presentation with the fact that, all the data I'm going to present, especially when I'm talking about differences in cases or incidents in different racial groups, this all has to do with disparities in underlying social determinants of health. It does not have to do with differences in, like health behavior, for instance. And, this is widely considered to be the case now, both in academic circles as well, kind of, at the level of the CDC. In fact, they have a whole web page devoted to social determinants of health and health disparity. So I just wanted to kind of put this out there at the beginning. And this is due to, lots of different reasons, differences in health access, systemic racism, and a few other factors that I'll talk about on the next slide. So, when I'm kind of pulling out specific, racial groups, I just want to make sure that it's within this context that we're discussing, cases and prevalence, and I'm not trying to, stigmatize certain groups. And in fact, we've, again, mentioned this past couple of presentations. This year, we actually have some local data to support this. And so we looked at STI rates for chlamydia, gonorrhea, and syphilis in 2020 at the census tract level, and then looked at 48 social determinants of health at the census tract level to see if there was an association between them. And we found that there was an association between either lower than expected or higher than expected STI incidence rates at the census tract level, based on certain social determinants of health. And you can see here, social determinants of health that predicted, lower than expected STI incidence really all revolved around access to healthcare, particularly employer healthcare. Factors that were associated with higher than expected STI incidence at the census tract level, you can see here, Medicaid insurance only, no health insurance, reliance on public transportation, and income below the poverty level. So what we found, in Durham County really supports this idea that social determinants of health underlie, these disparities that we're seeing as far as chlamydia, gonorrhea, and syphilis cases. And perhaps most importantly, there was no association between race and STI incidence of these 3 diseases, except for in historically marginalized neighborhoods, which again, it falls back on these other factors that we've talked about. So really kind of, what I found really interesting data that we found, but really dismisses this idea that, certain diseases are more prevalent in certain racial groups because of, differences in behavior or something like that. And you can see here, here's a link to the paper for anyone that's interested. So moving on, you can see here, chlamydia cases are up in 2023. We're predicting, really they're going to be higher than we've seen in the past 5 years. This coincides with increases in sexually transmitted infections nationwide. You can see here, since the 1950s, really cases of STIs are increasing kind of regularly and really increasing over the past, number of years. In Durham County over the past 5 years, 50% of chlamydia is occurring in people who identify as Black or African American. It's more common in females than males. And as you would expect, the vast majority of cases are in people between the ages of 18 and 29. Similar findings here with gonorrhea. You can see this projected increase in 2023, really, higher numbers than over the past 5 years. With gonorrhea, about 2/3 of cases occur in people who identify as Black or African Americans. Similarly occur in younger people, ages 18 to 29, followed by ages 30 to 39. And unlike chlamydia, males are more likely to be diagnosed with gonorrhea than females. And it's kind of interesting, the reason why. One of the reasons is thought to be that the bacteria, Neisseria gonorrhea, actually expresses different genes in men compared to women. And this difference in gene expression in males causes males to have more symptoms. And so they're more likely to present for care and get diagnosed. And so although we're seeing, more cases of gonorrhea in males, the prevalence, the number of infections, diagnosed and non-diagnosed is probably pretty similar between males and females. Syphilis, you can see this graph at the top right. Here's another one where, syphilis was really common in the first half of the 20th century, and then rates decreased. They are now higher than they were in 1950. We've seen a huge increase in syphilis over the past 20 years. We're seeing that here in Durham County as well. You can see here coming out of kind of the COVID pandemic, numbers are starting to creep up again. About 2/3 of cases occur in people who identify as Black or African American. And again, the majority of cases are in this younger age cohort. Males are more likely to be diagnosed than females. And then breaking down kind of the type of syphilis, you can see there's this decrease in cases between 2022-23. I think that's because, this data was censured mid-October. So, if we're adding in the next 2.5 months, I don't think we're actually going to see a decrease in cases. And then you can see here, similarly with a latent syphilis, probably not going to see a decrease from 2022 to 23. That's just has to do with kind of the fact that data was censored mid-October. Congenital syphilis has been all over the news for good reason. So there's a 1,000% increase in congenital syphilis rates nationwide over the past 10 years, which is really astounding. And so obviously COVID and lack of access to healthcare doesn't completely explain this, because this increase started before then. Fortunately, in Durham County, we're not really seeing an increase in cases. We typically see 3 or 4 cases a year, which is 3 or 4 too many. But thankfully, we're not seeing a big increase like is being seen elsewhere in the country. HIV, you can see here, we don't have data yet from 2023. That typically there's a delay getting that data from the state. I'm expecting that the rate of newly diagnosed cases is going to be higher than 2022, and so you can see coming out of COVID, where there was just less testing, we're seeing more cases. And one of the exciting things here, and I know you all are aware of this because you approve the funding for these positions, but we are in the process of hiring 2 new DIS officers. One of them is going to be a dedicated HIV bridge counselor for Durham County, which is really exciting. Their job will be to engage people with HIV back in care who are currently out of care. There's only a few counties in North Carolina that have their own HIV bridge counselor, so it's really exciting that we're getting one in Durham County. There's only about 10 statewide, and they are just really stretched too thin. So to have our own is going to be really exciting. Foodborne illnesses really pretty stable. Typically, from year to year, we always see a increase in cases over the summer when the weather is warmer. It's just easier for the bacteria kind of reproduce and cause cause foodborne infections. Perhaps more than any other communicable disease, the rates are really based on reporting, and the vast number of foodborne illnesses really go unreported because there's never a concrete diagnosis made. Most people, they feel sick for a couple days, they get better, and they actually never get kind of a pathogen identified. So these rates are really low compared to the true incidence. Tuberculosis, you can see, 2021, 22 during COVID, decreased number of cases. We now have six cases in Durham County of active TB that we've seen so far this year. So, about the same number of cases as we've seen the past couple of years. I also added in the number of latent TB cases that we've seen and of people that have accepted treatment. This is only for Durham County Department of Public Health. This is not countywide data because latent TB is not a mandatory disease that's reported to the state. But you can see here, we've really, coming out of COVID, we've really started treating a lot more latent TB, which is important because we have to treat and get out the reservoir because that presents reactivation in these active TB cases that can be so tough to treat. Hepatitis B cases really have been pretty stable, a little bit up and down over the past 5 years. It's not endemic here. Most cases are people that were born and raised in Asia, for instance, and moved here because it's endemic in Southeast Asia as well as some other areas. And males are more likely to be diagnosed than females with hepatitis B. Mpox, Bria talked about this a little bit. I just threw this slide on here just to show that we haven't forgotten about Mpox. We're still very vigilant against it. Fortunately, we have not seen any cases. We have not diagnosed any cases in Durham County since November 2022. But there have been some cases diagnosed in neighboring counties, so we know it's around, and we continue to be vigilant. And we also published an article this year on Mpox vaccination and the role of social vulnerability, and found really that we did a pretty good job vaccinating the most at-risk population, including those with other health disparities. So that was really kind of rewarding to see. Hepatitis C, you can see really pretty stable rates over the past 5 years. Again, cases more likely to be diagnosed in men. And then unlike other communicable diseases, rates are really pretty similar between whites and people who identify as Black or African Americans. Unlike other communicable diseases, diagnosis is most commonly made in people between the ages of 60 and 69. This is something I hope this starts changing. For you clinicians out there, the United States Preventative Task Force gave hepatitis C screening a grade B recommendation, which is a very positive grade. And so every adult should be being screened for hepatitis C. So we're hoping that younger people are going to start being screened more and more, and we're going to start making this diagnosis at younger ages. So I hope this age starts coming down, this age range. And we are really actively over the past year linking people who are newly diagnosed with acute or chronic hepatitis C with a HIV bridge, hepatitis C bridge counselor, which helps for Region 6, which helps link people to care so they can get treated. Invasive group-based strep, you can see we saw uptick in cases this year. Interestingly, group-based strep tends to follow other viral upper respiratory pathogens. And so in years where there's more viral upper respiratory pathogens, you tend to get more group A strep, which is a bacterial infection. We had a pretty large number of cases of RSV earlier this year, and so that's probably why we saw a little bit of an increase in group A strep this year. just a few slides on COVID-19. As you all are probably aware, tracking COVID-19 levels in the community, it's a lot harder now because cases are not being collected by the CDC and disseminated to the state and us because cases aren't being captured. Most people aren't getting PCR tests done now. They're doing rapid antigen tests at home if they're testing. And so we don't really have case numbers and percent positivity rates to look at like we did previously. So we're relying more on other metrics like COVID-19 hospitalizations and wastewater data. I think I've mentioned on probably at this presentation last year, even COVID-19 hospitalization is tricky because if you go to the hospital for a reason unrelated to COVID-19, for instance, you broke your leg and you're tested for COVID-19 and diagnosed with COVID-19 in the emergency department and admitted, that gets captured as a COVID-19 hospitalization. So oftentimes we're trying to dig deeper into this data to see, how many comorbidities do people have who are being admitted to the hospital. That gets us a little bit better idea that people who tend to be sicker at baseline are getting admitted with COVID, and maybe COVID's the culprit, but that's sometimes tough to discern. With that said, hospitalizations, this is through October 28th, really low right now. So 21 new admissions in the previous 7 days, that's very low. That's a rate of 4.3 new admissions per 100,000 population, and it's a 40% decrease from the previous 2 weeks. So all those numbers are really, really good, really low. Looking at wastewater data, so we have two wastewater treatment sites that collect this data. So our North Durham site, you can see here, viral loads really peaked in early September and have pretty steadily decreased since then. Same at the South Durham site, again, really peaked in early September and have decreased since then. So we're seeing a little bit of a COVID-19 lull right now, but I'm fully expecting sometime this winter we're going to see another resurgence. So as always, we are constantly on guard. Talked a little bit about this. We are offering the new bivalent boosters, both Moderna and Pfizer, here for both people with insurance and without insurance. And we, similarly to Mpox, we looked at our COVID-19 vaccine outreach efforts and really showed that the more we engage with the community, especially in populations where we were having difficulty reaching, we saw really a nice uptick in vaccination in those populations. And this was kind of a nice blueprint for our Mpox vaccine response. Whoops. Sorry about that. Last year. So again, really kind of, affirming data that we saw when we kind of looked into this. So here's a summary slide. I'm not going to go through it all, but we're seeing increased rates of chlamydia, gonorrhea, syphilis. HIV is probably going to be increased. No new Mpox cases, and everything else is pretty stable since last year. It truly takes a team, dealing with communicable diseases here in public health. And so I want to acknowledge all these people, particularly Savannah, our epidemiologist who helped put these slides together. And then our whole CD team here, you can see them really, we have such an excellent nurses, excellent staff here that really makes my job pretty easy. I'm happy to answer any questions.
Dr. Jenks, thank you very much for that great presentation, as always. I have two quick questions. Going back to congenital syphilis, I heard I think it was NPR article about this earlier this week. I think it said something like 30% increase year over year, but you mentioned that in Durham County, we were holding steady significantly below that. Any factors that you can highlight of why the rates here are significantly lower than what we're seeing, in other, 30% is just a wild number to me.
Yeah, no, that's a good question. I'm not exactly sure. Our cases are so low from year to year that it's kind of tough to tell. Well, when we've done X, Y, or Z, we've really noticed a difference. I mean, I think, and Rod can certainly attest to this. I mean, we've really made improving maternal and child health a huge priority here, and so I'm hoping that some of this is due to our outreach efforts, where we've really just had good outreach to that community and the providers who take care of our pregnant patients in Durham County, and that's helped keep the numbers low. Obviously, congenital syphilis can just be catastrophic for the baby, and so any case is one too many. So we're going to continue to work at it, but I'm hoping it's because we've just done a really good job with outreach to that population. It's a good question, though.
Wonderful. Thank you very much. And the last question, going back to the rates of HIV infection, and it's frustrating to see those numbers continue to go up despite the availability of PrEP and really good education now. I'm excited about the bridge counselor. Can you just talk a little bit more about sort of the timeline of that individual and sort of what they're going to do and how you think that's going to impact the rates in Durham County?
Yeah, so we've got it's a CDC funded position. So it's basically where the position is a DIS officer. So we've got two of those. The job posting should, I'm hoping, hit the Durham County Jobs website tomorrow. And so their job basically will be to track down anyone who is diagnosed with HIV but hasn't been engaged in care. And they've got different ways they can do that. There's a number of different databases, both statewide and nationwide, try to track down these folks. And it can be tricky because, we may think that there's 4,000 people in Durham County that have HIV that are out of care, but, a substantial minority of those folks may have moved out of state, and so it can be time consuming to try to track down those people. So that's why it's helpful to have, a dedicated bridge counselor. So at the state, they are so overwhelmed with trying to do this, and they have such few dedicated bridge counselors that they mostly try to target younger people with HIV who they think are most at risk of transmitting HIV. So they're not reaching people who may be older and less sexually active, which obviously we want to reach those people too. So, really excited to have them. The other exciting thing too is, we, Randy Rogers and I have been we've been meeting with Duke infectious disease physicians for at least a year now, kind of working on this. And they've got funding dedicated to have a part-time HIV bridge counselor at Duke. And so we're really hoping that we're going to continue to collaborate with them. So when we identify a Duke patient, for instance, that's out of care, we can really coordinate quickly with them so they can reach out to that person and get them back in care. And we hope to, expand this to, Lincoln providers and UNC providers. So this is a big, really a big initiative of mine. And then the other thing too, we've been prescribing PrEP here at the county for about a year now. And I think that's possibly one reason why, we're seeing a bit of an uptick. We've had at least a half dozen people come in here to get started on PrEP, and we've made the HIV diagnosis at that visit. And obviously not started them on PrEP, we've connected them to care. So there may be a little bit of that people are coming to see us because they want to get started on PrEP, and we're able to make the diagnosis at that time. It's a shame, that we've caught them, too late, but at least we're getting them diagnosed and on treatment.
Absolutely. Great. Well, that's really exciting about these resources coming on board, and look forward to hearing more about what they're able to accomplish once we get them on board and onboarded. So thank you very much.
Of course. If there are any other questions, I'm happy to entertain them.
Dr. Jenks, just a follow up on that. For the bridge counselors, did you say that it was what the budget for that is a grant from the CDC?
It's a grant from the CDC. It is funded through, I believe, January 2026. It was supposed to be longer, but the DIS funding nationwide got cut by about 80 million when the infrastructure package got passed last year. I don't know if any of this funding is going to get kind of reinserted, but right now we have them, I believe, through January 2026. And then, at that point, I'm hoping this bridge counselor, we can show that, what a benefit it is having them, and we can, hopefully find a way to keep them on,
Absolutely.
find other sources of funding.
And this was for 2 FTEs or 1 FTE?
So the 2 DIS positions we are hiring for now. It's two FTEs. It's 1 FTE each. Yeah.
Thank you.
Yep. Any other questions?
I just have one quick question.
Yeah.
In the 2 universities in the county, Central and Duke, so are students able to receive PrEP on campus, or do they come through the health department?
They are able to at NC Central, and this is something, I'm Randy and I are probably going to work more with these Duke ID physicians that we talked about. I mean, we'd really like to coordinate more with some of the universities, especially the HBCUs in the area regarding PrEP. The problem is at these employee health centers, there's a lot of turnover. And so, they have gone in and I've gone in, we will talk about PrEP and teach them how to do it. And then, in a couple of years, the clinicians turn over and it kind of gets dropped. And so we're going to try to come up with some sort of toolkit where we can really try to make this more sustainable. I will say, and I've heard this from some people, that they actually feel more comfortable coming here than going to the student health centers. So we will get them started on PrEP here and oftentimes refer them out.
Yeah, that's probably true. Okay, thank you.
Yeah, it's a good question.
Dr. Jenks, I had a question.
Oh, sure.
Thank you for this presentation. With regard to current hospitalizations, do you know how Durham is doing overall with RSV and flu and COVID? Just currently, do we have a lot of sick people, or do we seem to be doing okay?
I don't know. I can find out the RSV and the flu question for you. With COVID, where overall rates are low, I do believe that the people that are hospitalized, it's more people actually being admitted because of COVID. Our data analyst, JP Zitta, he routinely looks at this data, and he'll look at the number of comorbidities of people being admitted, and he can kind of tell if people are being admitted because of COVID. And it seems like a lot of these admissions are because of COVID, not incidental diagnoses. I'm not so sure about RSV and flu. We are in RSV season. We're smack in the middle of it, as you know, and we're at the early stages of flu season. I can get that data back to you if you're interested.
Thank you. Hopefully it's not that bad.
Yeah. If there aren't any other questions, happy long holiday weekend to y'all.
Thank you. I do have a question, but it's not related to your comment. Anybody in IT, my visual photo of me keeps blinking. I'm about to have a seizure. It keeps blinking and it won't stop. Is anybody else having that? Okay, maybe it was a presentation because it just went away. All
okay,
right,
probably because I was sharing, sorry.
No worries.
All right, great. Dr. Jenks, thank you very, very much. And then the last presentation for the night is our first quarter budget overview by Micah Guyton. Micah, if you're ready, go ahead.
Yeah. Good evening.
Good evening.
Put all my things up here. Okay. Can you see my presentation?
Yeah, we sure can. Your audio is a little quiet, but we can see your presentation.
I will speak up. How's that?
That's
Okay.
great. Thank you.
My voice is a little quiet, so I think it's more to blame on my voice, but good evening, everybody. I'm honored to be here this evening to share our fiscal updates from the first quarter of fiscal year 23-24. My name is Micah Gwyndon, and I'm the finance administrator here at the department. I have 10 slides for you, and I plan to take no more than 10 minutes. First, I want to share some of our current parameters that we're operating within this fiscal year. Our original budget when we started the year and at the county portion, our sort of bottom line is $28,642,035. That was $38.5 million in expenditures and $9.8 million in offsetting revenue. Since July, as you all know, we've had several budget amendments that each month the Board of Health reviews and approves. So some of those are listed here on the right. In addition, we have rollover funds every year that are funds that are encumbered on contracts and funds reservations from previous fiscal years that roll into the new year. So this $6.2 million is inclusive of all of those planned expenditures. Our current budget, including the original amendments and rollovers, is $44.6 million in expenditures. We have $13.5 million in offsetting revenue, making our bottom line. Oops, there we go. Or the county portion, $31,120,838. The next three slides we'll look at are about expenditures from quarter one. So we have two pie graphs here showing our budgeted expense categories. On the left, personnel, operating, and capital, and then our actuals for quarter one here on the right. Notably, a lot of time is spent in quarter one getting our many contracts executed. The department has lots of contracts, and so a lot of time is spent during quarter one on those and the associated invoices, getting those paid. So there's a bit of a delay on some of those expenditures. So I expect this 28% in operating to increase as those expenditures get caught up. Overall, we've spent 20% of our expense budget, which is a good place to be at the end of quarter one. The Department of Public Health's budget is broken into 29 cost centers or sections of our budgets, primarily by program area. So this chart represents the highest spending 15 cost centers for quarter one. These numbers do correlate with the cost centers with the highest budget. So for example, in administration and department and jail health, those three divisions have a lot of contracts in them, kind of our general administration contracts. So those are housed in those divisions. I also wanted to provide you with the highest expenditures across all of the cost centers. So here we have the 15 highest general ledger line items from all of the divisions. So personnel lines make up 7 of these 15 with contracts, notably right behind salaries. And then of course we have various supplies for our different medical teams. The last 4 slides are going to look at our revenue collection for quarter one. So on the left, we have the various categories of revenue that we receive at the department, and then the percent each of those contributes to the whole picture. So most of our revenue is from grants, a lot of state grants for mandated services. We have several federal grants and some smaller grants. Secondly, Medicaid is at the top, a top contributor, of course, to our revenue. And then our actuals, which for quarter one are here on the right. And those pretty closely align with the budgeted plan at this point in the year. We have grants coming at 61% and Medicaid at 30%. Here are the precise numbers per revenue type. there's always a couple month delay with grant revenue, as well as a delay with Medicaid and Medicare and private insurance. But we're pulling an overall percentage of 17% of our revenue for the year. I tried to wait as long as possible to pull these numbers because I wanted to get accurate revenue numbers. We tend to get revenue late and then put it back. But our overall percentage is 17 at this point in the year. Our service fees are, for the most part, in real time, and you can see those are right on track at 25%, 1/4 of the way through the year. And looking at this, we will definitely need to make some adjustments on our private insurance expectations for next fiscal year, as we're already exceeding our budget in that line. Lastly, you can see here the revenue categories that make up each of the highest revenue pulling cost centers. So health education, administration, tuberculosis screening are the 3 highest pulling cost centers. The Kelly green is grant revenue. A yellow is Medicaid, and light green is service fees. So there's a lot of cost centers and a number of these, but I wanted to just kind of give you a sense of how this is distributed. Like, for example, the DINE, this is all a grant. Health education primarily funded by grants. The tuberculosis screening cost center, that's where we budget the majority of our, what we call the COVID funds. So the additional funding that we've received the last few years that's still kind of rolling over from year to year in several of the pots. A lot of those are put and housed in tuberculosis screening. And so that's why that's particularly high. I appreciate everyone's attention and your leadership towards our fiscal matters. And I'm happy to take any questions that you have.
Anthony, you put your hand up first, so go ahead.
Thank you. Thank you, Ms. Winden, as always. Just a few questions.
Sure.
Would you mind just going back to page 3 for the... Yeah, awesome. So the sum of current budget, that column 2, and just to clarify for myself, that is year to date or the entire annual year budget. Is that correct?
Yes.
I see. Gotcha. And then so for the operating expenses, if I did my math correctly, we're about 60% or so, which kind of explains that delta that you're seeing there at 14% year to date. You mentioned that there are delays in, I suppose, contracts and potential grants. Does that explain the fluctuation to what we're seeing for operating?
Yes, I think so. I think we'll see that increase as well. We have done, I would say, particularly in October, we've been doing a lot of catching up on those. So I'm expecting that operating percentage will increase next quarter.
Gotcha. Excellent. And if you could go to page 7, please. Thank you. For the interlocal agreement, is that is that like a biannual hit, or we're doing pretty well, 49%. But I'm just curious if that is something that we would expect to still overperform for next quarter or not.
We won't expect that. This is a agreement that we have with, I believe it's just one agreement this year. Occasionally we'll enter agreements with the city of Durham or another, local government entity. Kind of will split the cost on some projects, and sometimes it's housed with us, sometimes it's housed with. And so I think this will, I think that 49 will level out.
I see. Gotcha. Thank you. Imagine it's probably pretty tough to forecast such fluctuations.
Yeah, I think that one is particularly related to the master aging plan, if I recall correctly. And so that was, yeah, I think this will even out. We may not even see a change in it in quarter 2.
Gotcha. Thank you.
There's just 1 or 2 activities in that particular line item.
Excellent.
That's correct, Michael.
Thank you.
And just one more question, and by no means is this something they have to answer now. If maybe you could perhaps just double check on my own research. With the 2 FTEs that Dr. Jenks had mentioned for the bridge counselors, I believe that is from the grant money from CDC. Again, please double check my notes. I was just reviewing some of our past meeting minutes, and I believe we had approved one bridge counselor back in February or March of this year to recognize the funds of around 44,000. I just want to make sure that that's the most up to date in terms of the grant money, if it's around 44K, and if we need to approve a second FTE or not.
Yeah, that's a great question. And it comes with a long story that others on the call started prior to me arriving. But that 44 that we approved was actually no funding. And so the other pot of it, my understanding was it was approved in the previous fiscal year.
I see.
And so the 44 was the additional, and that put us over to have enough to have the two positions.
So sure, like 88K probably for 2 FTEs.
I think it was actually more than that, but I don't know the
Okay.
top of my head.
Gotcha.
Yeah.
So certainly, if you just follow up, just make sure that we're all aligned for any approvals. So thank you so much.
Oh, absolutely. Yeah. There's been a lot of activity on that front between HR and finance and our department. So I know staff have been working hard on that, but yeah, I can get you the exact totals of those 2 positions for sure.
Absolutely. And more resources, the better.
Sorry, say that again.
More resources, the better. We definitely need it.
Yeah, we're when Dr. Jenks said we're excited for it to hit the website. We can't emphasize that enough. It's been a labor of love for a while for a number of folks.
It's awesome. I'm trying to spread the word. Thank you, Ms. Quinlan.
Thank you.
Commissioner Lum had a question.
I didn't have a question. I just want a comment I wanted to make. I mentioned this to you, Director Jenkins, at our last Monday meeting, but I just really want to uplift and thank the budget team and all of the staff at Public Health who apply for all of these grants, because we at our Board of Commissioner meetings love approving, accepting this grant money. And the Board of Health is always the board that comes, and like the Public Health Department is always the department that comes to us sharing that they found money versus asking us for more money. So just really want to highlight and thank y'all for that amazing work, because I know grant applications are not easy and there's a lot of competition.
Thank you, Commissioner Lum. And Mike and her team have provided that report that you requested, and that is forthcoming.
Right, Micah, I just have one last question. It's about the vehicles expense on the highest expenditure slide. I remember us talking previously approving purchasing new vehicles to replace some aging ones in the fleet. Is that like a total purchase expense? Are we leasing these vehicles? If you could just help me understand what that almost $62,000 is.
Yeah, sure. That is 2 vehicles that were purchased, I believe, last fiscal year, but have just hit the books this fiscal year because they've just arrived and are now in the environmental health fleet and have been very much appreciated by staff all around.
Great. Wonderful. Thank you.
Thank you all.
All right. Thank you very much, Ms. Winden. Really appreciate it. All right. Moving on down the agenda. The next items are responding to Board of Health questions. So the first item is the Public Health Vacancy Report. I took a look at that and it looked, pretty much as we would expect. Director Jenkins, anything there that you want to call out specifically?
Not particularly, Dr. Ray. For the most part, it's status quo. We have had some to go on to greener pastures, We've had some promotions, but for the most part, it's been pretty status quo.
Great, thank you. Any other questions from any other board members about the public health vacancy report? All right, moving on to the NOV report. Again, looked pretty much as expected. Anything there, Director Jenkins, you want to highlight? Or anyone else?
Not particularly consultation with environmental health. They pretty much said we're just kind of holding the line. Nothing new to report for this board.
Okay, wonderful. Anyone else have any questions about the NOV report? All right, lastly, the health director's report. Looked like, again, really good report, Director Jenkins. Anything that you want to highlight there?
Just for the sake of time and brevity, just want to lift up Ms. Joyce Page in the Men's Health Council. She does a fantastic job of always including him in our activities. And I happen to be a member, I want to say myself and Dr. McDougall, our chair, are members of the Men's Health Council. So we attend the walks when time permits, but definitely want to make sure that the board knows the value that's there. And Men's Health Month was celebrated, and they have a nice webinar in partnership with Duke coming up on sleep apnea. So we're hopeful that this board does receive some of those notifications, but Joyce keeps us busy.
Wonderful. Thank you very much. I had one question. It's about the NC Fit program. I noticed that it said that they stopped taking new referrals, and I was wondering if that was related to there's a vacancy in community health workers associated with that, if there was any updates there.
That is spot on. We did have to pause because we are in the process of recruiting 2 new community health workers. One in particular was let go to move on to his higher purpose, and the other actually received the promotion onto the national North Carolina, I guess the national FIT program, and we were sorry to see him go. However, super happy that he was thought of to really be able to be the lead community health worker for the nationwide effort. So we're on pause, but I have all the faith in the world that we're going to find the right applicants. As you all know, it's a little bit of a tricky position in that we really have to hire someone with lived experiences, and that tends to really require us to really be a little bit more pensive about the right fit. But we look forward to providing this board with some additional updates once we're fully staffed.
Wonderful. Thank you very much. Anyone else have any questions about the health director's report? All right. Thank you very much, Director Jenkins. Next item is committee reports. I don't see anything that is due this month. Unless any board members have anything related to their committees that they want to discuss here. All right, looks like there's nothing under old business. So we'll move on to new business, and it looks like we have 3 budget amendments to discuss.
Yes, sir. And again, thank you to the board for hanging in there. A lot of great presentations. I'll be very brief. The board has been requested to approve, number one, the board has been requested to approve the relocation of 2 known and 3 probable grave sites located within the abandoned cemetery identified as the Emory Cemetery under the supervision of the health director or health director's designee pursuant to North Carolina General Statute 65-106. This request is being made by the current property owner, Mr. John G. Upchurch, to provide for the perpetual care, safer access, protection from further vandalism, and to reunite the decedents with other deceased family members. So that's the first action for the board. The second is the board is requested to approve budget amendments to recognize funds in the amount of $59,743 from Guilford County. These funds are intended to be used to offer training and professional development to our staff, members of our local health department, Guilford County serves as the lead county for our Region 5 ARPA workforce development efforts. And this is just an interlocal agreement to ensure that we receive our pot of the money. So that is what this is about. And finally, we have the board is requested to approve the budget amendment to recognize additions to the Department of Public Health's fee schedule and to submit a change to the charge master rate. On September 11th of this year, the Food and Drug Administration approved new COVID-19 vaccines for the 2023-2024 season. With these new vaccines that are available primarily through commercial pathways, the addition of 8 current procedural terminology or CPT codes, and I won't go into them, are certainly needed for DPH's fee schedule to allow the department to request reimbursement from commercial payers to include commercial insurers, Medicaid, Medicare for the cost of said vaccines and the administration fee. Additionally, CPT code 90619 is also needed to be added for to properly bill for the meningococcal vaccine. So those are the 3 amendments for your consideration, Mr. Vice Chair.
Thank you very much, Director Jenkins. Just one quick question about the first one, the grave site removal. I'm assuming that we have the appropriate jurisdiction to rule on this. That's been vetted. You know, this is just. It seems unusual that would come to us for involvement.
Indeed.
Yeah, I was wondering about that too. Didn't we have a previous discussion about grave site and removal past few months? Is this the same site?
I believe that it is a different site, Dr. Jackson, but this is under the board's purview under the general statute that has been indicated, particularly as a power vested by the public health director to ensure that it's carried out properly. And that is something that our experts in environmental health will ensure is done with dignity and respect.
Okay.
All right, wonderful. Anyone have any questions? All right, I will entertain a motion to approve these amendments.
Seconded.
So moved.
Moved and seconded. Roz, if you could help us with the roll call. Do we can do one for all 3?
Yes, sir.
Okay, wonderful.
Dr. Wright,
Yes.
Commissioner Alam, Dr. Jackson.
Yes.
Yes.
Thank you.
Yes.
Dr. Brightway,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Mr. Gregorio,
Yes.
and Dr. Glover. Thank you.
All right, wonderful. Thank you, everyone. Next item under new business, agenda items for the next meeting. Any items that board members want to see highlighted in the next meeting, or Director Jenkins that you have planned for the next meeting?
Yes, sir. Next meeting is specially dedicated for your training. So Rosalind and I will ensure that you have that individual from previous years who has spent many years in the field of public health to provide you with that update and that guidance. So please be on the lookout for more information, but I promise he's going to make it as quick and enjoyable as he did the last time. I see Commissioner Alam has a question.
Hey, yeah, that reminded me, Director Jenkins, I received an email. There's a PhD student, well, now finished and now a associate professor who was looking for someone from our public health board to come and speak to his students about the Board of Health and the trainings that like Board of Health members undergo. He teaches now at UNC Gillings.
I know exactly who you're talking about, Commissioner Alam. Thank you for bringing that to our attention. We have tried to make that scheduling work. However, we did run into a little bit of scheduling conflict, but we have committed to getting back with that student at a later date. I know the student personally, and we will do our best to make that happen.
Awesome. Thank you.
Absolutely.
Yeah, and I'd just be interested in getting just a little brief update about our infectious disease numbers related to COVID, RSV, and flu after the Thanksgiving gatherings. If we have that information available, then might not be available till January, but
We will do our best to get it to you if it's available, Dr. Jackson.
And if I can second that, Dr. Jinks, you don't have to answer my question this week. You know, it would be fine if we tabled that, the question about those infections, to tag it on to Dr. Jackson's query.
Yeah, Rosalind's going to send out the statewide data. It basically shows that, RSV levels were up. RSV related hospitalizations about a month ago, they've come down. They're still, a little bit high. And then flu related hospitalizations have been increasing over the past month. That's statewide data. If you're interested in countywide data, I can, talk with JP, our data analyst, to see if he can track that down.
That answers my question. Thank you.
Okay.
Worried about those.
All right, wonderful. Sounds like we're going to have a good training session next meeting and get an update on some of our numbers. Next on the agenda, any informal discussion? Well, I will just, number one, thank everyone. We had some great presentations today. Thank you for the time you took in putting those together, and for educating us on those important topics.
yeah, absolutely. Great staff.
Agreed. And the breadth of the information, that was impressive.
Yeah.
All right. Well, the next item is a motion to adjourn. So unless you guys want to keep talking, I'll entertain a motion.
I gotta go
So
to bed at
moved.
8 o'clock.
Second.
All right. Motion seconded. Roz, if you could have us with a vote.
Dr. Wright,
Yes.
Commissioner Alana,
Yes.
Dr. Jackson,
Yes.
Dr. Brightway,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Mr. Gregorio.
Yes.
Thank you.
All right. We are adjourned. Thank you very much, everyone, for your time today. Have a wonderful and safe Thanksgiving holiday, and we'll see you next month.
Thank you all. Enjoy
Be
the
safe.
long
Thank
weekend
you.
holiday.
For coming in.
You stay
Thanks,
safe.
Dr. Ray.